The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, and I'm here with Inside JACC. And one of the major questions confronting us at the moment is the relative role of carotid artery stenting versus carotid endarterectomy for patients with cerebrovascular disease. And we've got a really interesting study in press in JACC, and here to discuss that with us is Dr. De Rango. Dr. De Rango is a vascular surgeon, and she works at Misericordia Hospital in Perugia. Tell us a little bit about your study, Dr. De Rango.
We decided to evaluate our long-term results at 5 years after carotid stenting and carotid endarterectomy in order to investigate which are the durability of the procedure and the risk of stroke after this treatment for carotid stenosis, especially because the European randomized trial have published very negative results in stenting. And we reviewed our experience, that is single-center experience, and to evaluate the perioperative but also the long-term results.
Well, we were very pleased to see it's a very large group, 2,000 patients, 1,000 in each arm, followed for 5 years.
For 5 years. This was not a randomized study, obviously, but we balanced the two populations, carotid stenting and carotid endarterectomy, by using a propensity score. And we found that our results were, our risks were very low, and with rates that were similar to those published by the CREST study that was published just in the same period we was analyzing our results. We found that regarding the perioperative period, the risk of stroke and death was only 2.8% after carotid stenting and 2% after carotid endarterectomy. We also analyzing symptomatic and asymptomatic patients. In symptomatic, the risks were higher in both procedures, but without difference between the two treatments, and the same was for asymptomatic patients. Again, it was in asymptomatic 4.5% in carotid stenting and 2.9% carotid endarterectomy. Therefore, the rates were very low. I also found that the cardiac death in perioperative period was higher after carotid endarterectomy because we did not have any death with carotid stenting. And obviously also the cranial nerve lesions were higher after carotid endarterectomy. After the perioperative period, the risk of stroke was low, 0.8% ipsilateral stroke after stenting at 5 years, and 2.5% in carotid endarterectomy. We also analyzed the composite endpoint, including any perioperative stroke and death rate and any ipsilateral stroke at 5 years. And again, there was no difference between stenting and endarterectomy, with the rate only 3.7% after stenting and 4.7% after carotid endarterectomy.
Well, these are really very optimistic results. Low side effects, adverse event rates, regardless of which procedure was used, and essentially similar results in these two groups, whether they underwent carotid stenting or carotid endarterectomy. Was that your basic conclusion?
We believe that our inclusion criteria were important to obtain these results. We started this study after our learning curve. It is very relevant for stenting to obtain good results after the learning curve. During this training, we learned how to select the best patient suited for stenting and those best suited for carotid endarterectomy. For instance, we prefer to exclude from stenting those patients with adverse anatomy, especially with adverse arch anatomy, such as the presence of atheromatous plaque on the arch or difficulty in passing through the arch, as well as those patients with angulated carotid or calcified carotid, all patients that we prefer to exclude from carotid angioplasty. Another issue is the use of cerebral protection that is important to obtain low risk of stroke during carotid stenting. And we also exclude from stenting old patients because also in our experience we found that our octogenarian patients got worse with stenting, probably because they had adverse anatomy more frequently than other patients.
So if I have carotid disease now, maybe the conclusion is I have to go to Perugia because it's a single-center study. Do you think that other centers can learn your criteria for determining which patients go to surgery and which patients go to stenting?
I believe that the center with experience can do this. Whichever center who passed a learning curve can learn how to best manage a patient toward carotid arterectomy or towards stenting. This is not only our center. Whichever center with good experience after the training can understand which is the best treatment for that particular patient and obtain good results with carotid arterectomy or carotid stenting.
Well, excellent data. Given the limitations, and we have to say single study, retrospective, not randomized, but a large group followed for 5 years, showing that really good results can be obtained if you carefully select those patients for carotid endarterectomy and those patients for carotid artery stenting. Thanks very much for being with us. For Inside JACC, I'm Tony DeMaria.